I'm Dr. Christoph Correll of the Zucker School of Medicine at Hofstra Northwell in Hempstead, New York. Welcome to our expert-driven psychiatry case presented by the Journal of Clinical Psychiatry. Today, we'll be discussing 3 cases of patients with schizophrenia and the pros and cons of switching these patients from oral to long-acting injectable antipsychotics. The first patient case I will be discussing is James, a 33-year-old white male who was diagnosed with schizophrenia at the age of 22. James is unemployed and lives at home with his elderly parents. He has few social contacts and spends most of his time either gaming or intermittently using marijuana. James' mother is upset that her son is not leaving the house and not doing anything with his life. There have been frequent conflicts over her checking up on James taking his medication because she's worried about another psychotic episode. Recently, James required rehospitalization for an acute psychotic episode after he was beaten up by strangers in the park. He stabilized on the unit and is currently taking oral risperidone. He tolerates it well, except for an asymptomatic mild prolactin increase. As part of the discharge planning, which different maintenance treatment options would you discuss? The second patient case for today is Joanna, a 43-year-old Black female who has had schizophrenia since the age of 28. She lives in supported housing. She has comorbid social anxiety and gained more than 40 pounds on her past and current antipsychotic regime combined. Her weight gain has plateaued and her current BMI is 29, but except for mild elevated triglycerides, her glucose and lipid parameters are still currently within high normal limits. She also complains of mild daytime sedation. Joanna's psychotic symptoms are generally well controlled, and her social anxiety is more of a concern for the patient, although it is sometimes difficult for her to distinguish social anxiety from paranoia. Joanna is coming to the outpatient appointment accompanied by her guidance counselor, who relates his concern that Joanna has been telling him that she wasn't sure that the medication was necessary for her anymore. She says that she feels fine and wants to return to a normal life, and that the medication side effects have really interfered with her daily routines. The guidance counselor relates to you that he has seen the patient get somewhat more easily agitated and that she seemed preoccupied. At this point, what treatment options would you consider and discuss with the patient? Our third and final patient case is Tom, a 21-year-old Asian male who has moved back in with his parents and has been living with them for the past 3 months. He had his first psychotic episode in college at the end of an intense 1-month exam period. He felt stressed, did not sleep enough, and used some marijuana to relax in between his study sprints. Tom started hearing commenting and derogatory voices and became highly paranoid about his roommates, who he believed was tampering with his brain when he was asleep. He was also convinced his roommate was plotting together with several other peers to have him fail the exam. Tom was hospitalized after he attacked his roommate. He stabilized over 3.5 weeks on oral aripiprazole, which he tolerates reasonably well, except for sleeping 1 to 2 hours more than usual and having gained 2 kilograms of weight. The weight gain stabilized partially due to regular exercising. Tom wants to go back to college and is very concerned that a new relapse could interrupt his academic progress even more. He will also be returning into a dorm living arrangement and is ashamed of his past behavior and mental illness. In a survey of 206 schizophrenia patients with more than 3 months of long-acting injectable antipsychotic treatment experience, 67% of such patients said they felt better than they had been feeling before when they were taking oral medication. And as many as 70% of patients reported that regular contact with a doctor or nurse who administered their injection made them feel better supported in their illness. Moreover, 88% of patients in the survey reported never having missed an injection without prior discussing this with their clinician. Long-acting injectable antipsychotics, or LAIs, have other advantages over oral antipsychotics. In addition to markedly reducing or at least visualizing non-adherence, LAIs provide a stable blood level of medication, which avoids first-pass hepatic metabolism. LAIs also eliminate the risk of accidental or intentional overdose. Moreover, the risk of relapse and hospitalization is reduced, and LAIs have been associated in several studies, including national databases, even with reduced mortality, more than oral antipsychotics. Furthermore, because LAIs require regular contact with the clinical team, progress can be more closely monitored to identify early warning signs of relapse. In addition, since LAIs eliminate the possibility of covert non-adherence, treatment sessions can be used to discuss other aspects of care and a patient's life. And when relapse occurs, clinicians can focus on psychosocial issues, substance abuse, or other causal factors. Non-adherence to oral antipsychotic medication is one of the most common as well as preventable causes of a schizophrenia relapse. Research has shown that about 61% of patients with schizophrenia are at least partially non-adherent to oral antipsychotic treatment. In fact, early phase and first episode patients with schizophrenia who have the most to gain and the most to lose may be at particular high risk for non-adherence and related relapse. In a nationwide Finnish database study of 2,588 patients with a first hospitalization for schizophrenia, as few as 46% continued their initial antipsychotic treatment for 30 days or longer. Importantly, non-adherence is closely related to relapse risk. A naturalistic study that followed 876 patients with schizophrenia for 1 year after hospital discharge found that the relapse rate among adherent patients was only 21%, compared to 55% in non-adherent patients, 1 in 5 to 1 in 2 patients. In a survey of perceptions about medication use, patients with schizophrenia were less likely to agree that the good things about medication outweighed the bad, 61% of patients. Then were psychiatrists, where 81%, or family members, 80% said that the good outweighed the bad. However, patients who have tried LAIs often have a favorable perception of them, as do families and caregivers. Among those individuals currently receiving an LAI antipsychotic, as many as 73% reported a positive perception of LAI use, indicating again we're more afraid of something we don't know about than learning about the benefits of something that we have experienced. LAIs have been shown in multiple studies to be beneficial during first episode schizophrenia. Evidence suggests that although efficacy differences may not exist among oral non-clozapine and second-generation antipsychotic agents to a relevant degree, the injectable formulations have clear benefits over their oral counterparts. A recent study found that LAI treatment lengthened time to first hospitalization in patients with early phase schizophrenia, and that many patients would try it when the treatment team was adequately trained to offer long-acting treatments. Additionally, in a real-world comparative nationwide database effectiveness study that included almost 30,000 patients, long-acting treatments and clozapine were the most effective treatments for preventing schizophrenia relapse. Rehospitalization rates among patients receiving LAIs were 20 to 30% lower than for patients receiving equivalent oral formulations. Based on these accumulating data, The Florida 2019-2020 psychotherapeutic medication guidelines for adults with schizophrenia recommend as a level A strategy either continuation of an oral antipsychotic or even a preemptive or proactive switch from the oral to a long-acting injectable antipsychotic in first episode patients with schizophrenia who are currently benefiting from and are currently adherent to an oral antipsychotic that works for them and that they tolerate well. Long-acting injectable antipsychotics, or LAIs, have the potential to reduce non-adherence, relapse, rehospitalization, and even mortality, even among patients with first episode schizophrenia and with comorbid substance use disorder, which are often hard to treat. Long-acting formulations can be a very powerful strategy in helping ensure that patients get the benefit of the medication they have been prescribed, as the use of LAIs is more easily monitored than oral medications due to the nature of their administration to patients. Second-generation antipsychotic medications have been available as long-acting treatments since 2003. Several clinically proven LAI schizophrenia treatments are currently available, including paliperidone, aripiprazole, olanzapine, and risperidone, and others are emerging. First-generation antipsychotic LAI preparations, such as haloperidol decanoate and fluphenazine decanoate, have recently been compared with the second-generation LAI agents, and both formulations demonstrated comparable efficacy in preventing relapse. However, adverse effects and patient acceptability differ at times substantially between first and second generation oral antipsychotics as well as long-acting injectables. LAIs differ regarding their initiation strategy, use of loading doses, or need for time-limited oral co-treatment, duration and flexibility of injection intervals, in addition to the differences of the antipsychotic that the LAI formulation is based on. Patients should be offered the option of LAI antipsychotic treatment and should understand the logistics and the potential benefits of that kind of regime, as well as the potential side effects. To optimize outcomes, clinicians should employ shared decision-making with patients. That also involves motivational interviewing so that they understand that the treatment selection is there to help them reach their goals. Patients want to be involved in clinical decision-making, but often feel uninvolved in the choice of their treatment. Those patients who have been allowed to take a more active role in the clinical decisions have clearly reported greater satisfaction with treatment and, relatedly, are more likely to accept the use of LAIs and be more adherent. Educating patients about the benefits of LAIs often results in greater acceptance. A 2013 study by Potkin and colleagues found that after clinicians addressed the issues causing patient resistance, more than half of the patients agreed to start an LAI treatment. Patients who started LAI treatment then reported perceiving more rapid symptom improvement and greater overall efficacy than they had experienced in the past with oral antipsychotics. Like their oral counterparts, LAIs vary considerably in their propensity to cause certain adverse effects that can interfere with patient acceptability and functioning, including sedation, weight gain, metabolic side effects, extrapyramidal symptoms, and prolactin elevation, as well as related sexual side effects. And these differences can be used to guide the oral and then LAI selection that might be most appropriate to the given patient in front of us. Paliperidone palmitate is now available not only in a 1-monthly and 3-monthly, but also a 6-monthly injection formulation, making it the first LAI antipsychotic agent to extend the dosing administration beyond the typical monthly or even 2-monthly dosing interval. These longer duration in formulations have demonstrated a low propensity for adverse events and a high rate of symptom remission with reductions in positive and negative symptoms, indicating meaningful functional remission. The reduced dosing frequency has a favorable impact on patient preference and diminishes the burdensome aspects of treatment, increasing patients' likelihood for treatment continuity, which is crucial. In general, long-acting injectable antipsychotics, or LAIs, are very well tolerated and efficacious. Relapse rates with LAIs have been shown to be significantly and clinically meaningfully lower than with oral treatment across actually all 3 available study designs, which includes randomized controlled trials, cohort studies where the clinician chooses either to use an oral or an LAI treatment, and especially in mirror image studies where the patient acts at their own control, which emulates clinical practice the most. We compare the time before we make a change to the time after we made the change. And in this case, the change is switching from an oral to an LAI medication. This superiority of LAIs across these 3 designs over oral antipsychotics is in large part due to the elimination of covert non-adherence and the reduction of non-adherence in general. LAI formulations of antipsychotic drugs offer additional advantages over oral medications. Evidence shows that LAIs are not only suited for situations of poor adherence or when oral antipsychotics don't work and have failed, but also as an excellent option for first-choice treatment and long-term maintenance treatment. Database and randomized controlled studies favor the use of LAIs in early-phase schizophrenia patients, and time to first hospitalization is significantly delayed by treatments with LAIs. Maintenance therapy is pivotal in relapse prevention, and acute and long-term objectives must be linked early in the treatment of schizophrenia. In this context, the early use of LAIs is part of a preventive as opposed to a reactive approach, as data indicate that relapses can seriously undermine the biological, psychological, and social underpinnings of subsequent treatment success. Relapses are serious events that alter disease trajectory and are most often related to non-adherence. However, symptomatic worsening can also occur during LAI treatment, also called breakthrough psychosis. Management options include ruling out or addressing medical illness or substance abuse or misuse as a contributing factor of breakthrough psychosis, addressing psychosocial stressors, optimizing non-pharmacologic treatments, treating medical and/or psychiatric comorbidities. We also need to ensure proper LAI administration technique and addressing missed LAI doses or a delay in the injection that is taking place, subsequently diluting the blood level. That can lead also to a lack of steady state attainment, which results to then inappropriate low blood levels. Finally, we may have to add an oral medication to the LAI to check whether that is helping the patient so that at the next injection time point, we can then elevate the dose of the LAI. If we're already at the maximum dose, there could be the off-label practice of then shortening the injection interval to indirectly elevate the blood level. But again, after we've checked that the addition of oral medication of the same type as the LAI has improved efficacy and not reduced tolerability. If none of these strategies is successful, though, the patient might need to be switched to another antipsychotic, either an oral or ideally again in an LAI formulation, given the benefits of LAIs over oral treatments. Finally, inadequate treatment response to antipsychotic should be assessed clinically and ideally using a rating scale. This could include, for example, the one-item Clinical Global Impression Scale, or CGI, or the more comprehensive but still short 6-item positive and negative syndrome scale, the PANS-6, that both due to their brevity can be applied in clinical settings. If the clinical impression or either of these 2 rating scales reveals ongoing symptoms of moderate or greater severity, such as delusions, hallucinations, conceptual disorganization, and/or disorganized behavior, after at least 6 weeks of treatment with 2 different antipsychotics that are tolerated and given at a dose that is therapeutic, and if functional impairment of moderate or greater severity exists, then the patient can be considered antipsychotic treatment resistant. However, in order to rule out the so-called pseudo-resistance, the TRIP guideline group also recommended trying at least 1 LAI antipsychotic for 3 to 4 months to ensure continued presence of relevant psychosis despite assured medication intake, since a lot of the treatment-resistant patients might be resistant because they're not taking adequate doses that they are prescribed. If treatment resistance is confirmed, guidelines recommend initiating low-dose clozapine treatment and titrating the dose upward while monitoring blood plasma levels until symptoms subside or improve sufficiently. If symptoms and functional impairment continue despite of adequate clozapine dosage, guidelines then recommend electroconvulsive or ECT therapy or augmentation of clozapine with another antipsychotic agent. Having reviewed the relative merits of long-acting and oral antipsychotics, let's check back in with our 3 cases. So let's think back about James, who had a mother who was very worried about another episode, who had been rehospitalized, likely to not having taken the medication as prescribed, was beaten up by strangers because he was acting most likely strangely, and who may not be taking medication as he should, plus maybe weighed down by the interaction problems with the mother who belittles him by always checking on him. Would this patient not be able to benefit potentially from a long-acting treatment, taking away the conflict at home, assuring treatment, but also with his prolactin increase, having maybe less peak-trough variation so that the prolactin levels would decrease also? Let's now think about Joanna. What were her problems? She was on medication that gave her side effects, weight gain, metabolic abnormalities that are in the borderline range, but also feeling sedation and complaining that the side effects interfered with her daily routines. She is seriously questioning whether she should even take the medication, feeling fine. What we often see then is patients stop the medication and feel shortly better because the immediate effect of the medication is gone and they don't get a relapse right away. So they're lulled into the safe security that they can stop. Talking about a long-acting injectable can help the patient restabilize who was just getting more easily agitated and preoccupied, who may run into trouble with other patients in the group home or even potentially lose the ability to live there or have to be rehospitalized. So talking to her about the long-acting treatment option, finding a medication where she may not be as impaired by the side effects, and then linking the stability to the medication she's taking as a long-acting formulation could help resettle the treatment plan into an area where she can remain stable and have an improvement in her functioning and quality of life. Now let's think back about Tom. Tom is young, he's 21 years old, he's in college, and he had this psychotic episode that really unhinged him, but he's back on track. He responded well, like many first episode patients do. He's on a medication he can tolerate reasonably well, and he's really worried that he will have a relapse. What can assure being relapse-free for the longest time? It is a long-acting treatment. And it's also a long-acting treatment where in a dorm environment, he will not be seen taking medications, where the self-stigma and potential discrimination will not add to the stress that he wants to avoid further psychosis. Also, as we all know, in college environments, there is some marijuana or other drug taking. And in that environment, often the medication is not taken at the same time, bringing the risk for psychosis even higher. So here again, having the backbone and the seat belt that we can give Tom to have a stability in the college environment, putting his mind to his studies rather than having to remember taking the medication, would be a best start on the road to recovery and also success.